Good morning. Welcome to our patient seminar, and I'm delighted that I'm able to talk to you about the role of arrhythmias and ICDs, so defibrillators, in hypertrophic cardiomyopathy. So to start off, what are arrhythmias? So arrhythmias are irregular heartbeats. Instead of a steady rhythm, your heart may race, may pause, or may beat unevenly. And some arrhythmias can lead to serious problems like sudden cardiac arrest or stroke, and it's important to know that in HCM the risk of arrhythmia is higher, and there are effective treatments available. So that's why I don't want you to feel anxious when we talk about arrhythmias, but hopefully I will inform you about all the possible treatments that are available for arrhythmias. So when we talk about arrhythmias, there are three different aspects that we need to cover. Arrhythmias can be either too slow, so your heartbeat can be too slow. Those are called bradyarrhythmias. The heart rate can be too fast. Those are tachyarrhythmias. And the heart rate can be irregular. Those are extra beats, or you can have an arrhythmia that is very common in HCM. It's called atrial fibrillation. And importantly, we also then divide, are the arrhythmias coming from the top chamber of the heart, like in atrial fibrillation, or are they coming from the main pumping chamber? Those are the arrhythmias that we're a little bit more concerned about because they can have more serious consequences. So to start off with heart rhythm that is too slow first. So understanding the heart's electrical system is important. So primarily the heart is a pump. It's a muscle that pumps blood through the body. But in order for the pump to beat, you need somebody that gives that heart that impulse, and that's the electricity in your heart. And we all have a biological pacemaker in our heart that's in the top chamber of the heart that beats around 60 to 80 times per minute. That impulse has to get to the main pumping chambers, which are the bottom chambers. And you see these yellow lines. This is a specialized conduction system, like a special wire that's built into the heart. And the electrical impulse travels over these wires to the bottom chambers of the heart. And those wires conduct the electricity very fast to the bottom chambers and make sure that all chambers beat in a synchronized fashion. So as you age, now this conduction system, this electrical system in the heart may slow down. And as you slow down, as you age, the heart rate may become slower. However, in HCM, as we heard from Dr. Madrazo, we have often obstruction, that we have this bulge of heart tissue that gets in the way of the blood flow, and we treat that with medications. And the most common medications that we use in HCM are calcium channel blockers or beta blockers. Now, both calcium channel blockers and beta blockers may also slow the heart rate down, so that's an important reason for patients with HCM to have a slower than normal heartbeat. And if your HCM doctor says, well, we really need to keep you on those medications, but your heart rate gets too slow, well, in that case, you may need a pacemaker. So what is a pacemaker? A pacemaker is a little computer with a battery that we implant under the left collarbone, and it's connected to the heart with usually one or two wires that we implant in the heart. Those wires are called leads. Those are insulated wires. And we anchor them in the heart and connect them to the pacemaker, to this little computer that we put under the skin. And then this little computer monitors, registers every single heartbeat that you have. If you have a normal heartbeat, let's say 60, 70 beats a minute, it won't do anything. It will just sit there and monitor your heartbeat. But if your heartbeat drops below 50 or 60 beats a minute, then it will pace your heart and prevent your heart rate from going so slow. And there are different types of pacemakers available. They are the ones with the leads. We figured out over time that those leads can also be a cause of problems. They can break down, they can get infected. So nowadays we implant also leadless pacemakers. That's a relatively new thing that we do. They also have a battery life of 10 years, and they work really well for selected patients. Now, what is important is that the pacemakers, they are good if you have a slow heart rate. I told you before that patients often tend to have a faster heart rate in hypertrophic cardiomyopathy, and that faster heart rate can come from the bottom chambers of the heart. And the pacemaker, they are able to deal with a slow heart rate, but not with a fast heart rate. And the fast heart rate that we are very concerned about is called ventricular tachycardia or ventricular fibrillation. Those are dangerous rhythms that are arising from the bottom chambers of the heart. And here's one of those instances where you see on the ECG that can record the electrical tracing of the heart, your normal rhythm, and suddenly you can go into a very chaotic, very fast rhythm that looks very different to the normal rhythm. And if that happens, the heart essentially ceases to pump. And it's like a medical emergency. If the heart isn't pumping, there's no blood reaching the brain. And if that rhythm doesn't terminate on its own or is not interrupted by a physician, then you're in trouble, in deep trouble. And how do we interrupt that rhythm? Well, we defibrillate. And it's what you see in the movies where you can put a defibrillator on the chest and then shock the heart back into normal rhythm. And so who is at risk of sudden cardiac death? Well, it's important to know that sudden cardiac death is a catastrophic complication of HCM, mostly caused by ventricular arrhythmias. In some patients, sudden cardiac death may also be the first manifestation of the disease. It's a common cause, as we heard before, of sudden cardiac death in young athletes. However, it's important to know that the annual incidence, so the rate of sudden cardiac death, remains very low. It's less than 1%. However, there is a subset of HCM patients who are at higher risk. And it's very important to identify that subset of patients who are at higher risk because sudden cardiac death is preventable by implantable defibrillators, which we call ICDs. As I told you before, you can either defibrillate externally. That works well if it's a witnessed cardiac arrest and you happen to be in a high traffic area. Let's say you're in an airport or you're in a casino where you're monitored and within minutes somebody's there with a defibrillator. But if you're at home, you're by yourself and you're at high risk of having a dangerous arrhythmia, what we do is we implant a defibrillator under the skin. Now, this is similar to a pacemaker. It's a little computer with a battery that can monitor your heart rhythm. But not only is it able to pace if you have a slow heart rate, but also if you go into a dangerous fast rhythm, that defibrillator is able to defibrillate you. It's important to know that the very first defibrillator was actually conceived and built here in Baltimore. And the first defibrillator worldwide was implanted here at Johns Hopkins Hospital in 1980. So we have a long tradition. And those defibrillators are built similar to the pacemakers, that they have a wire that goes to the heart. And they are new defibrillators that have been developed, where we really try in younger patients to keep this wire outside of the blood vessels, because we know that it's relatively easy to place that wire, but it's not so easy to remove. They grow inside the blood vessel, you form scar tissue inside the blood vessel, and if it ever needs to be removed, it can be very, very tricky. It's a more complex procedure. So what we do now is to implant defibrillators outside of the blood vessels. One option is the subcutaneous ICD. It's a slightly larger device where the wire, it's located not under the left collarbone but on the side, and there's a wire that goes across under the skin and then it goes up on your breastbone. And so under the skin but on top of the breastbone. And then there is another defibrillator now, it's called the extravascular ICD, that also stays outside of the blood vessels, where the device is located on the side, the wire goes across and then goes underneath the breastbone. So that's a relatively novel device, but we're really trying to push for that in younger patients who have to live with a defibrillator for many, many years, where we know that there's a high likelihood that they may require at some point a lead extraction because the lead breaks down and we need to deal with that. Now, it's important to know that sudden cardiac death overall is rare, and most patients with HCM do not need a defibrillator. So how do we identify those patients who need a defibrillator? Well, first, if you ever have a cardiac arrest and are lucky enough to survive it, no questions asked, that's the highest recommendation. Those patients absolutely need a defibrillator because we know if you had a cardiac arrest, there's a very high risk that you may have another cardiac arrest down the road. That is easy, but what about for patients who never had a cardiac arrest? How do I identify those who may be at highest risk? We know that there are several risk factors. One, if you have a family history of sudden cardiac death in a first-degree relative before the age of 50. If you have a personal history of passing out, and it's not a passing out episode that is due to common faint, that you got up too quickly, you felt a little bit dizzy and lightheaded, and then you fainted. But it's a fainting episode that when you report it to Dr. Madrazo and I, we don't like the way it sounds. It's like sudden onset, you drop to the floor, you wake up, you have no idea how you got there were no warning signs. Those are the ones that are concerning. If you have severe thickening of the heart muscle, so a heart muscle should be less than 1 centimeter in thickness. If it is greater than 3 centimeter, we know that this is a significant risk factor. If you have an outpouching of the heart at the tip of the heart, we call this a left ventricular apical aneurysm. We know that those are associated with an increased risk of sudden death. And then last, if your heart function in hypertrophic cardiomyopathy is lower than expected, even a little bit lower, that increases the risk, because what typically happens in hypertrophic cardiomyopathy is that the heart muscle actually is stronger than normal. We also know that there are minor risk factors, like if you have scar on your cardiac MRI, if you have non-sustained ventricular tachycardia, so if we do an ambulatory Holter monitor and we find that you have frequent runs of a faster rhythm that may progress into ventricular fibrillation, that's a risk factor. And patient age also matters. If you present at a younger age, that's more significant than if you present at the age of 60 or 70. So what tests are necessary to assess the risk of sudden cardiac death? Well, the prior cardiac arrest, the family history, and the syncope, so the passing out episodes, that's something that we can figure out just by talking to you and getting a good history. Imaging studies are equally very important. So it's either the echo or the cardiac MRI to look at the structure of the heart, to see whether your heart is strong, whether it's too thick, whether you have an apical aneurysm, whether there's scar on the cardiac MRI. And then we do ambulatory ECG monitoring. So we record this ECG over prolonged periods of time to see whether you have these brief runs of non-sustained VT that are concerning, that would signal that you're at high risk of developing a dangerous rhythm. Importantly, the genetic test right now is not required for adults as a risk factor for implantation of defibrillator. This may change in the future. There is more emerging data that patients who have certain genetic variants are at higher risk, but currently that's not reflected in the adult guidelines. In the pediatric guidelines, that started already to change, but for adults, genetic testing is not important for sudden cardiac risk stratification at this moment. So you could say, well, if the defibrillator is so great and prevents sudden cardiac death, it's like having EMS in a box with you at all times. Why don't we all get defibrillators? Well, there is a certain risk of putting a defibrillator in. There are some small surgical risk of bleeding, infection, injury to a blood vessel or the heart, collapse of the lung. This wire may dislodge that we put in the heart. That's overall rare, but what we really worry about are long-term complications with defibrillators. If you're young, you need a defibrillator for a lifetime. I commit a young person to having repeated surgeries. There's a risk of infection, and I told you it's very messy if you have a transvenous device, so a device that has leads in the heart, and they need to be removed. And last, it's a little computer with the batteries, and who has ever seen a computer that can malfunction? Well, very rarely what can happen is that you can get, the computer can, or the ICD can be fooled in thinking there is a dangerous rhythm when in fact there is none, and you could get an inappropriate shock. So you can get a shock when you don't need one. Those are very painful. Patients can get PTSD. So it's very important to really assess the need for a defibrillator and to implant defibrillators in those patients who are at highest risk. So what about restrictions for patients who live with an ICD? So importantly, we want you to have a normal life with the defibrillator. We don't put a defibrillator in to restrict you, but in order to allow you to lead a normal life. There are very rare professional restrictions, and importantly, those restrictions are not because you have an ICD, but because you have a condition that can lead to a sudden cardiac death risk. So if you're a bus or truck driver, they don't really want you to do this if you have a defibrillator or if you are at risk of dying suddenly. Likewise, arc welding is one profession that is difficult if you have a defibrillator, because the arc welding emits so much energy that it can be picked up by the device, by the defibrillator, and it looks like you have a cardiac arrest and it can activate the defibrillator. It's a little bit more difficult to get MRIs with a defibrillator. The problem is that there's no ICD that is labeled by the FDA as MRI safe. The labeling by the FDA is only MRI conditional, which means, yes, you can have an MRI, the device will withstand that. However, it needs to be turned off before you go into an MRI scanner. You need to be monitored when you're in the MRI scanner. It needs to be turned on again when you come out. And that's more labor intensive. It's more personnel intensive. We can do very few studies during the day. And there's a long wait list to get in if you have an ICD and you need an MRI. What about exercise? We heard before that we really encourage patients with HCM to do physical exercise. We do not want you to become couch potato. That's similar if you have an ICD, that doesn't change, but ideally we would like you to avoid contact sports. So last, I want to talk about the irregular heart rhythms. Fortunately, sudden cardiac death in HCM is rare. What is common, a very common arrhythmia in HCM, is called atrial fibrillation. That's an irregular rhythm that is fast and can be very irregular and can lead to a lot of complications. The very first one is that if you are in atrial fibrillation, the upper chamber of the heart ceases essentially to beat and the blood flow slows down to the point that you can form blood clots in the top chamber of the heart. And they form particularly in what we call the left atrial appendage. It's an outpouching in the top chamber of the heart. And if the blood flow slows, you can form blood clots there. Little parts of that blood clot can break off. They can travel with the bloodstream, and the first vessels that take off after the heart go to the brain. And if a blood clot travels to the brain, then you can have a stroke. So it's very important to identify patients with HCM who have atrial fibrillation because they need to be on a blood thinner. Now, there are several types of blood thinners that you may have heard about. There's warfarin or Coumadin. We had that for more than 50 years. It's a very cheap anticoagulant, very effective, but it requires continuous monitoring. It can interact with certain medications, and more importantly, you have to have a very consistent diet. Otherwise, the levels will be all over the place. It can be that you're not taking enough, or it can be that you're taking too much, and then you're at risk of bleeding. If you're taking too little, then you're not protected from a stroke. So it can be very difficult to manage in individual patients. So the newer blood thinner called DOACs are much easier to take. It's sort of one size fits all, doesn't require much monitoring, and we preferentially use those these days. Now, there are some selected patients who are at high risk of having a stroke, but who cannot take blood thinners, because once we put them on blood thinners, they start bleeding. And then we're sort of stuck between a rock and a hard place. What do we do with those patients? And there is a procedure now available. It's called a Watchman device, where we put a device, it's called this Watchman, in the left atrial appendage. That's where 90% of all the blood clots arise. And it's like a little umbrella that we place there through the groin. You see the delivery catheter coming up, and we can go to this left atrial appendage, put the Watchman device there, take the delivery catheter away, and this effectively closes up this left atrial appendage. It separates it from the remainder of the heart. So if you form a blood clot in there, it's not able to travel through the heart and give you a stroke. The other important aspect to know about atrial fibrillation is that it can cause palpitations, shortness of breath, and it can also worsen heart failure. Patients feel miserable, many patients, when they have atrial fibrillation. They don't like to feel the palpitations. So we then decide, in addition to anticoagulation, how can we treat the atrial fibrillation? And this is either by medications that work on affect the electrical properties of the heart and stabilize normal rhythm and keep the AFib away, or we can do an ablation. So what is an ablation? An ablation is also a catheter-based procedure where we come up with a catheter from the groin and go into the heart. And we know that the AFib starts in the left atrium, in the left upper chamber of the heart. And there's a hot spot around those pulmonary veins, and we can either burn or freeze those pulmonary veins, or we use a novel technique called pulse field ablation, and this is a procedure that I did last week in a patient with atrial fibrillation. You can see the before and after images. What you see here is the left atrium, the left upper chamber of the heart, and the electrical activity. What you see is there are 4 veins, or in this case 5 veins, 2 on the left, 3 on the right, that drain blood from the lung into the heart. And we know that where the veins enter the heart, it's sort of the hot spot. It can create a little bit of irritability in the heart muscle, and you're more likely to have extra beats and AFib originating from those areas. The electrical activity is color-coded. You see purple is normal electrical activity. When you get out into the veins, it becomes red. Red means scar. There's no electricity there. And what we do with the ablation is we extend the scar into the heart muscle, It doesn't affect the heart muscle, the pump function at all, but it quiets down this electrical hyperexcitability and minimizes the risk of atrial fibrillation. It's a procedure that's done under general anesthesia, takes about 2 hours, and it's actually quite effective to minimize the risk of AFib. So I just want to summarize that arrhythmias in HCM require proactive monitoring and management to minimize the risk of sudden cardiac death and also comorbidities related to atrial fibrillation. There's a critical role for ICDs in high-risk patients to reduce the rate of sudden cardiac death, and importantly, HCM requires a multidisciplinary team. It requires HCM experts, requires an electrophysiologist who's familiar with seeing patients with HCM. The risk assessment for sudden cardiac death is one. The other, because we're dealing mostly with patients who are younger, so we really would like to avoid this transvenous leads, find defibrillators that are suitable for younger patients. And then also the management of atrial fibrillation can be a little bit more tricky in patients with HCM. You tend to have more recurrences, so we need to be more aggressive with ablations and also with antiarrhythmic medications. With that, thank you very much for your attention, and we'll be happy to take your questions afterwards.